Okay, so I wanted to thank everyone for coming tonight or to listening in to our virtual advisory board for MOASC. And the discussion will be around extended endocrine therapy decision making in relation to breast cancer index. And we have Dr. Shauna Battle, who's going to be presenting this information to you tonight. So feel free to ask any questions along the way. We want this to be interactive and very helpful to you in your practice.
All righty. Well, I will jump right into this. So to start with, we'll be kind of starting with understanding the evolving landscape for extended endocrine therapy. And to set the stage, today we'll be focusing on patients with early stage hormone receptor positive breast cancers. And one of the defining characteristics of hormone receptor positive breast cancer is that these patients have an overall good prognosis. However, greater than 50% of recurrences occur after 5 years. So there's this long horizon of risk of recurrence that never seems to quite go down to zero. And this observation brought about a series of clinical trials to try to understand if there is a benefit from extended endocrine therapy. And here are some of those trials are summarized before you. This list is not at all exhaustive. However, we're showing here 6 trials of over 25,000 women where these women have received varying treatments, so TAM to AI, TAM to TAM, AI to AI, for varying durations. And what the data there's only a marginal benefit. So what we see is this data has been fairly consistent. However, how do you really identify which patients are among those likely to benefit from this extended endocrine therapy versus those who are not? So as you all know, when it comes to extending endocrine therapy, the balance of cost to benefit becomes increasingly critical. Endocrine therapy does come with its side effects. It really impacts the quality of life of patients. These drugs are not benign. And we see there's only this marginal benefit, but these patients are at risk of adverse events, which include bone toxicity, endometrial cancer, as well as tolerability challenges. So it's really important to ID which patients will truly derive that benefit and be spared these adverse events and side effects if they're not deriving any benefit from that extended endocrine therapy. So one of the themes I will be emphasizing throughout this talk tonight is that prognostic factors here are distinct from predictive data when it comes to determining benefit from extended endocrine therapy. So when selecting those patients for a longer duration of endocrine therapy, it's important to consider that many of the standard ClinPath factors, as you see here, and genomic assays can be used as prognostic tools, but these factors do not reliably predict or ID which patients will derive that benefit from extended endocrine therapy. And some of the common factors that we have been mentioned in discussion with peers is that quantitative ER and PR, Ki-67, menopausal status. These are some of those ClinPath factors that many physicians rely on as predictive components, but we find consistently throughout our studies that although these components are indeed prognostic to an extent, they do not reliably predict which patients will benefit. And this is where a test such as BCI can come in and really help support and give valid data for being able to make that decision. So what actually is breast cancer index? So breast cancer index is 2 tests in one. You get this predictive component, which is over here on the left in the purple. This predicts the likelihood of benefit from extended endocrine therapy. And it's used as a separate algorithm based on the HOXB13 over IL-17 BR ratio. And for the remainder of the talk, I'll refer to this as H over I. And essentially what H over I is doing is it's interrogating estrogen signaling and really letting us know, does this patient truly have an endocrine-driven tumor biology or not? The prognostic component is a bit more traditional and comprehensive. It assesses the individual risk of late distant recurrence, and we provide a percentage there. This prognostic component is a different algorithm, and it was validated in different studies. So this algorithm includes these 5 genes here, which are known as molecular grade index genes. They assess proliferation as well as that H over I as well. So it's additive, this prognostic component. So you have MGI plus H over I. So As of January 2021, breast cancer index was recognized by the NCCN guidelines for really helping guide that extended endocrine therapy decision making. And as of April 2022, ASCO recognized breast cancer index to really help guide that extended endocrine therapy decision. So here we're looking at some of the language pulled directly out of the ASCO manuscript. And here we see BCI may be offered to patients with 0 to 3 positive nodes who have received 5 years of endocrine therapy without evidence of recurrence to guide decisions about extended endocrine therapy. And these patients could have received TAM or an AI or a sequence of TAM followed by AI. And ASCO explicitly says here that Oncotype DX, EndoPredict, Prosigna, Ki-67, and IHC4 are identified as having insufficient evidence to predict benefit from extended endocrine therapy. NCCN guideline inclusions really highlight some of the trials that I will go through a bit more exhaustively here in a few slides that got us recognized by these guidelines. But here they're saying, down at the bottom, these patients who have that H/I low or a no on that test report derive no benefit from extended adjuvant therapy. So again, we're now recognized by ASCO and the NCCN guidelines to really help predict extended endocrine therapy benefit. So here's the table really from the NCCN guidelines, where a lot of these assays you probably use Oncotype, MammaPrint, Prosigna, EndoPredict, and Breast Cancer Index. And all of these assays have something in common where they're all prognostic. However, we'd like to point out here you have Oncotype, which is really that chemo predictor, right? BCI answers a different question. We're that extended endocrine therapy predictor. And we really kind of pick up where Oncotype really does leave off. So we're in our own unique space. All of these tests are prognostic, but only BCI can predict extended endocrine therapy benefit. So here we're looking at the utility of BCI and the timeline of when it would actually be good and fits into treatment planning. So our clinically indicated population is hormone receptor positive, early stage, so node negative or node positive with no more than 3 lymph nodes, and patients must be disease free. Typically, we hear the physicians start this conversation around years 3 to 5, and that's when BCI is ordered. And again, remember, you're getting 2 tests in one. So you'll get that likelihood of benefit, which is the predictive component. It will be that binary yes or no, as well as that individual risk of late distant recurrence in years 5 to 10, and that will come as a percentage on the test report. So next we'll jump into the proof of concept and validation studies that actually enabled us to be recognized by these guidelines. So this is the summary slide of our predictive studies, and I just want to set the tone that when I talk about benefit in terms of breast cancer index, our endpoint is RFI, recurrence-free interval. So we're looking for local, regio, and distant recurrences. So I'll start over here in the gray. This is Stockholm. This is our proof of concept study done at time 0. So these patients received TAM versus no therapy for 2 or 5 years in the adjuvant setting. And what we see is those patients who stratify as a yes or a high predictive, they derived about a 65% relative risk reduction. Whereas those patients that were a no, they derived no significant benefit. And this was the first study to show that the BCI is really speaking to the endocrine sensitivity of these patients' tumors. And I'd also like to point out that this study had about 20 years of follow-up, and this was a node negative only cohort. So for us, this was the first evidence to show that the BCI has a strong predictive ability at the time of from the time of diagnosis. However, we were interested in the extended setting, and I will go a bit more into detail about these studies presented before you. Before I move on, I'd like to point out that we consistently see throughout all of the studies that there's about a 65% relative risk reduction regardless of the cohort for those patients who are a yes or a high predictive. And we consistently see, regardless of the cohort, those patients that are a no or a low predictive derive no significant benefit, and it's about a 50-50 split there. So now we'll go a bit more into detail in the extended setting data. So here we're looking at the MA17 validation study. So this study was a mixed population. It was actually the first study that introduced node positive patients. So this was a 60% node positive cohort. And we also examined the extended setting. So here the patients received TAM for 5 years. Those that were disease-free were randomized to receive an AI or a placebo for an additional 5 years. In the parent study, we saw that there was about a 4.6% absolute benefit for all comers. However, for this MA17 BCI validation study, this was a nested case control study here. And we see once you stratify those patients into H over I low and high, we see that the no's or the lows derive no significant benefit. And that was about 51% of the patients. Whereas the yeses, they derived about a 16.5% absolute benefit. And that was 49% of those patients in this case control study. Odds ratio 0.35, which in turn we see a 65% relative risk reduction. However, we knew that wasn't a common sequence. So this is a bit of an older study where we looked within the trans-atom cohort. And here, this is a node positive only cohort I'd like to point out. And these patients received TAM for 5 years in the adjuvant setting. Those that were disease-free were randomized to receive tamoxifen versus stop for 5 additional years. And I'd like to point out that our translational team had decided that the node negative cohort wasn't appropriate to test due to this underpowering. So here we will only see the node positive cohort. So when we look at the data for the all comers without even stratifying with the breast cancer index, we see about a 4.3% absolute benefit. The moment you stratify these patients using the breast cancer index, we see the H over I lows derive no significant benefit, even in this node positive only cohort. And this is about 49% of patients. Then we see over here, those yeses, they had about a 9.7% absolute benefit, and that was about 51% of the patients here. Hazard ratio 0.33, which in turn is about a 67% relative risk reduction. I'd also like to point out that trans-atom was actually in a bit of an older study. So we didn't have the data regarding if the patients were in 1 and 2 and 3. We only have a yes or no to whether or not the patients were node positive or node negative. So we speculate that because this is an older study, that maybe there's an overrepresentation of those higher order nodal statuses such as N2s and N3s because the disease was getting diagnosed a bit later. So here we see consistently, as before, there's about a 67% relative risk reduction with 12.6 years of follow-up from randomization. And even in this node positive cohort, we did see that BCI does stratify some of these patients into having a no or H over I low, which means they did not benefit from extended endocrine therapy. So next up was IDEAL. This was the first study introducing the AI to AI population. And it also addressed that lingering question of, can these patients cut their endocrine therapy shorter at 7.5 years, or do they really need to extend out to the full 10 years? So the way this study was set up was these patients received either TAM monotherapy, an AI monotherapy, or TAM to AI for 5 years in the adjuvant setting. Those that were disease-free were randomized to receive an AI for an additional 2.5 years, or an AI for an additional 5 years. So what we see in this data is when you look at all comers without stratifying these patients using the BCI, we see that there's about 4.9% absolute benefit, which is in line with what we see in most of the extended endocrine therapy trials. But the moment you stratify these patients by using this biomarker, we see that about 53% of this cohort falls into this H over I low or no, meaning they derive no significant benefit, whereas 47% stratified into this yes, deriving about a 9.8% absolute benefit, hazard ratio 0.42, a relative risk reduction of 58%. So while I'm here, I also wanted to briefly touch on the SALSA study, and I'd identify some of the key differences between SALSA and IDEAL. First off, SALSA is definitely a lower risk cohort. They had definitely more node negative patients. IDEAL was about a 73% node positive patient, and we also had larger tumors. So just IDEAL was a much higher risk cohort. as well as the SALSA study didn't use a biomarker such as breast cancer index to further stratify those patients and really get a closer look at what's going on within their tumor biology, whereas IDEAL did do that. So IDEAL really did just indicate that there are some patients who truly do benefit from staying on for the full 10 years and do not need to cut it short at 7.5 years. So here, next we're looking at a pre-specified subset analysis where we looked at patients who only received any type of AI in that first 5 years in the adjuvant setting. So what we see here is when you look at the all patients without stratifying them, there's about a 6.1% absolute benefit. The moment you stratify these patients who received any AI in their first 5 years, we see about 53% fall into this no or H/I low, which means they derive no significant benefit, whereas these 47% fell into this yes or H/I high, and they derived about an 11.8% absolute benefit. So in turn, we see a hazard ratio of 0.34, which is about 66% relative risk reduction. And lastly, B42, this was our largest study, about 2,100 patients here. And this study was really turned out to be positive for us. In the beginning, it was a bit of a challenge, but overall, the results were consistent. And how this study was set up was the patients received either an AI or TAM to AI in the first 5 years. Those that were disease-free were randomized to receive an AI or a placebo for an additional 5 years. And what we see here is consistent with previous studies. BCI was able to identify patients with statistically significant benefit for distant recurrence prevention. So we see a hazard ratio for distant recurrence prevention of 0.29, which is about 71% relative risk reduction. So next, we'll kind of pivot a bit here and talk a bit more about our prognostic evidence across 4 trials. So while our predictive studies are so exciting and it sets us apart into this very unique space, we also include prognostic information on the test report, and it's very distinct within itself and validated in separate studies. And we are unique in our ability to provide this residual risk of recurrence in years 5 to 10. So our prognostic evidence includes node negative as well as node positive patients, pre and postmenopausal patients that receive TAM or an AI. And I like to always point out here, this TransATAC study, we had an opportunity to go head to head with Oncotype DX. And this is some of the prognostic evidence that really does set BCI apart as well. And I'll touch a bit on that in a few slides as well. So next, we'll talk about understanding and applying the breast cancer index results. So here you're looking at an example of the breast cancer index test report. We really try to make it as patient-centric and as easy to understand for you all as possible. So on the top here, you have that predictive component, which is just solely that H/I. Am I likely to benefit from extended endocrine therapy? It will always be a binary yes or no present in this box. On the bottom, you'll have this percentage. What's my specific risk of late distant recurrence? That's the prognostic component. Remember, it's additive for MGI plus H/I. And this new test report, excitingly, actually does the math for you. So here we see a patient's prognostic result of just 5 years of adjuvant endocrine therapy. And since she is a yes and truly does have an endocrine tumor biology, if she continues on for 5 years into that extended setting, she can reduce her risk by about that 58 to 67% relative risk reduction. And the math is done for you. On the contrary, here's an example of a test report that is a no. You see here on that top predictive component, this patient does not have an endocrine-driven tumor biology. And here, regardless of if this patient stays on for 5 versus 10 years, that risk, it's still going to be 8%. So next we'll pivot and talk a bit about the impact on the clinical practice and really shift into understanding standardizing extended endocrine therapy recommendations based on appropriate tools. So we recognize that when you look at a patient's presentation, you already have some idea of their risk based on ClinPath factors. However, here we're looking at summary data, which shows the increased value of genomic evaluation, as patients can be miscategorized based on ClinPath factors alone. So over here on the left, we have patients assumed to have clinically high-risk disease, so they are N1. BCI identified 22% as having a limited risk, so 2.1% of late distant recurrence, and 69% of those were not likely to benefit from extended endocrine therapy. So these are patients that may be assumed they need to stay on. However, we are seeing that some of them could avoid this over treatment. Next, on the right, we're looking at patients who are assumed to have clinically low risk disease, so T1 and zeros. BCI identified 25% as likely to benefit from extended endocrine therapy and are at a higher risk of late distant recurrence. And these are patients that may be slipped through the cracks and be told, oh, you do not need to stay on based on ClinPath factors alone. However, we want to avoid that under treatment there with those patients. So this really does point to how the genomic evaluation of these patients' individual tumor really helps identify which patients are appropriate for extending therapy versus those that are not. This slide is really emphasizing that same sentiment. Here we're looking at data from the IDEAL study, where BCI identified patients with high-risk clinical features. So we're looking at node positive or patients with tumors T2 plus in size who experience no benefit from a full 10 years of therapy. So these are those high-risk patients. So when we look here at these Kaplan-Meier curves, they're essentially on top of each other. And despite these patients being high risk, they do not benefit. And we can see those outcomes. And this is years after randomization that this data still does hold true up to 10 years. On the right here, we see quite the opposite. BCI identifies patients with low risk clinical features, so T1s or grade 1s, who experience a significant benefit from a full 10 years of therapy. So if we look down here at this Kaplan-Meier, we see that these patients had about 11.9% absolute benefit. So if they truly do have an endocrine-driven tumor biology, they do need to stay on for that full 10 years and not cut it short at 7.5. And we can see those outcomes and events there. So I like to always say when I get to this slide, we're really just reaffirming the importance of biology versus anatomy here. So next we'll shift a little bit and we'll look in here. We're looking at along the x-axis, the percent of ER positively stained cells and PR positively stained cells down here on the bottom. Along the y-axis, we're looking at the risk of recurrence. So what this data is showing from the trans-atom analysis is there's this consistent benefit that's just not varying based on the percentage of ER or PR positively stained cells. Also like to point out that Genomic Health also demonstrated in the B42 study that ESR1 mRNA levels provided no evidence that they could actually inform on extended letrozole therapy after 5 years of extended endocrine therapy. So here we are, just to orient us, here we're looking at on the left, these patients who are no on the predictive component of the test report. On the right, we're looking at patients who have a yes on that test report, meaning they do truly have an endocrine-driven tumor biology. If we focus here on this red line, these patients have stayed on endocrine therapy for only 5 years, but they are a yes for that predictive component. And we can see that there is a significantly increased risk of their recurrence. However, if we look at this black line here, these patients who are a yes and stayed on endocrine therapy for a full 10 years, we see that their risk of recurrence is significantly decreased. So this is again just showing that BCI is able to identify which patients will truly benefit, which patients truly do have an endocrine-driven tumor biology, and they should stay on for that full 10 years to get the maximum benefit. So here we're looking at the comparative performance of breast cancer index versus that oncotype and the trans-ATAC cohort. So this is a head-to-head of our prognostic component. And what we see here is that while both biomarkers are able to significantly prognosticate early recurrence, so years 0 to 5, only BCI is able to statistically significantly prognosticate risk of late distant recurrence. So again, years 5 to 10. So breast cancer index is really doing something unique in years 5 to 10. So the impact on clinical practice, we see in the data here that BCI results change physician treatment recommendations regarding extended endocrine therapy in about 40% of patients. This is new data from the BCI registry study that was presented at SABCS. So about nearly 1,000 patients here. Here we're looking at many of the reasons that these patients discontinue on extended endocrine therapy. Side effects really prominent that we hear within the field. Some aren't even sure if it's even helping. And we know from studies that about 40% of women are actually not even compliant with the extended endocrine therapy. And with that comes negatively, it negatively affects outcomes. So not sticking with that treatment plan is really worse effect associated with worsened outcomes, and we can see it here depicted in this data. So here we're looking at a study that also looked at the decisional conflict for patients and physicians. And what we see is that about 82% of patients recommended for extended endocrine therapy stated they would be more likely to be compliant based on the BCI results. So having their individual tumor biology assessed really makes it personal and allows them to make informed and personalized decisions. So what we see here is that both the patient and physician decisional conflict significantly decreased following breast cancer index testing. So here, kind of in, summing it up with our indicated use, we do accept patients who are pre and postmenopausal, lymph node positive, so 1 to 3 positive nodes, and lymph node negative, tumor size T1 through 3, grade 1 through 3. We do accept HER2 positive and HER2 negative. Patients must be ER and or PR positive, chemo treated or untreated, disease-free, and ductal and lobular histology. So just to summarize this all up, breast cancer index is really a decision for you and your patient. Is this patient likely to benefit from an additional 5 years or not? This provides you this actionable information that is based on the patient's tumor biology. And the second important question that is really answered here is, what is her individual risk of late distant recurrence? And we understand those numbers mean a lot to different patients, and we really want to provide you all with the data to having these personalized and unique conversations tailored to the patient. So again, in summary, we're intended to inform on extended endocrine therapy decision beyond 5 years for early stage hormone receptor positive patients. As now, BCI is the most validated commercially available test that predicts benefit of endocrine therapy beyond 5 years, making it the best tool to determine if that treatment is really right for that patient. And only breast cancer index is recognized by ASCO and NCCN guidelines to help guide endocrine therapy decisions. So with that, I will take any questions that anyone has. Do I see any in the chat?
So I have a question. So you said you should order the BCI index in year 4.
Yes.
Is there a reason to do it in year 4 and not sooner?
So typically we say between years 3 to 5. Are you trying to get at why you can't order it at time 0?
Order it year 1 or year 2. The reason I say that is because sometimes, you know, some of the pathology specimens are not stored. I don't know. Sometimes I don't get the thing if it's about over 3 years or 3.5 years. So is there a reason to do it? I mean, what is the rationale behind that?
Yes. So you are the physician. You can order the test whenever you would like to order it. We say to order it around years 3 to 5 because, again, we're informing on late distant recurrence years 5 to 10. So that's where we're validated. As of now, we are not validated to be used at time 0. We're hoping to, embark on studies to get indicated at time 0 and recognized for that. But that's the reason why, because of where our validation studies were done.
Question is for patients who are HER2 positive, just because they have more aggressive disease, that's why they were not included?
HER2 positive patients were included throughout our studies. They represent about 9 to 13% of the population. We do see by doing interaction analyses and looking at the those forest plots that HER2 positivity does not seem to impact breast cancer index. We've also looked at clinical experience data where we see that the HER2 positive patients really a majority of them do stratify into benefiting from extended endocrine therapy and having a higher prognostic risk in clinical experience data, but we do accept HER2 positive patients as well.
So you would do for HER2 positive patient also this, because in your clinical indication, it said hormone positive, HER2 negative.
Well, we're recognized by guidelines for HER2 hormone receptor positive, HER2 negative patients. However, our company does accept HER2 positive patients because they were included in our clinical studies.
Last question is, what about patients who get neoadjuvant chemotherapy?
Neoadjuvant chemotherapy, we do accept as well. Neoadjuvant endocrine therapy, we do not accept. We see that neoadjuvant chemotherapy, the meta-analysis studies don't really show a difference in the prognostic outcomes for our breast cancer component, how it was validated. However, we did not assess patients that received neoadjuvant endocrine therapy, and that's why they're not allowed to be accepted within the breast cancer cohort clinically indicated population.
Thank you.
You're welcome. Any other questions? All right, Nicole and Christy.
All right, thank you so much for presenting that information. We truly appreciate it. We'll go ahead and share the recording with our members, and if there's any questions, we'll follow up with you separately. Thank you so much. Have a great evening.
Thank you.
Bye-bye.
Bye-bye.